Hey everyone, welcome to this explainer on arthroscopic knee surgery coding protocols. Arthroscopic surgery is an absolute game changer for patients. Tiny incisions, super quick recovery, it's fantastic. But behind the scenes, the medical billing is a complete minefield. Today, we're going to expertly guide you through these frustrating, highly complex Medicare rules to help you prevent those dreaded denied claims. We're demystifying the red tape together so you can nail this on the very first try. Let's jump in.
Here is our quick roadmap for today. First, we'll navigate the general arthroscopy coding minefield. Then look at washing and clearing joints. Dive into the incredibly strict synovectomy rules. And finally, wrap up with cartilage and misalignment fixes.
All right, part 1, the arthroscopy coding minefield.
Okay, so to really understand why outpatient multi-procedure surgeries face such heavy restrictions in the first place, we've got to look at the ultimate rulemaker. Because it's so incredibly easy to just do multiple procedures in a single arthroscopic session, payers, especially Medicare, clamp down hard on what they'll actually pay for on one single calendar day. This is all driven by the NCCI, the National Correct Coding Initiative. Now, I know these limits can be absolutely agonizing, but really understanding the NCCI policy manual is your first line of defense against claim denials. You've basically got to think like the NCCI to survive the minefield.
A perfect example of this NCCI logic is CPT Code 29870. That's your base diagnostic arthroscopy. I want you to think of this code like a giant Russian nesting doll. Why? Because it inherently gets swallowed up as an unbillable component in pretty much every other knee arthroscopy procedure out there. It's the parent code. You would only ever report it separately if looking around inside the knee was literally the only thing the surgeon did that day. The second they actually fix something, boom, 29870 gets packed away inside that larger procedure code.
Moving right along to part 2, washing and clearing joints.
So let's see how these rules start stacking up when the surgeon performs distinct therapeutic actions. Take code 29871, lavage. This is when the joint is flushed with saline, typically for an infection or severe arthritis. But listen, you have got to be incredibly careful here. Payers watch this specific claim like a hawk because there is a long history of misbilling in the industry. If you're reporting a lavage, your diagnosis codes must rock solidly support it. I mean, zero ambiguity, or that claim is bouncing right back to you.
Now, what about loose body removal? Code 29874. This covers taking out fragments like an osteochondritis dissecans piece. You'd think that's straightforward, right? Well, generally speaking, removing a loose body is just considered an inherent part of whatever else you're doing in that knee compartment, so it's usually not separately billable. So when can you actually bill for it? The answer is, honestly, kind of wild.
Get this, the CPT manual dictates you can only report this if the fragment is the same size or larger than the instrument you're using. Ironically, this means the manual literally mandates that a surgeon must make a bigger hole just to prove the loose body was big enough to justify billing for it separately. The surgeon has to place a separate, larger cannula, make a completely new incision, or purposefully enlarge the portal just to get it out. If they don't document those exact physical steps, no way you can bill 29874.
All right, part 3, the strict synovectomy rules.
We are officially entering the most dangerous part of the minefield. There is a massive difference between two procedures that sound super similar but are coded totally differently. On one hand, you have code 29875, the limited synovectomy. That's taking out a single synovial fold or plica with a motorized shaver. On the other hand, code 29876 is the major synovectomy, which means shaving synovium from two or more distinct compartments of the knee. Let's break down the rules for the limited one first.
For a limited synovectomy, the CPT separate procedure rules kick in. This means you only report it if it's the solitary procedure for that entire encounter. The NCCI manual's language is absolute here. Doing a simple cleanup on the same knee is never separately billable if you're doing another more extensive procedure. Honestly, from a billing standpoint, you can only separately bill $29.85 if it's done on the opposite knee. If it's the same knee, the ipsilateral knee, it is 100% bundled.
Now for the major synovectomy, 29876, things get mathematical. To build this code, you have to do what I like to call compartment math. The rule says it must involve two or more compartments, but, and here's the kicker, you cannot count compartments that are already being used for other procedures. So let's say the surgeon does a medial meniscectomy, code 29881. Well, that code totally swallows the medial synovectomy. To legally justify adding 29876 to that claim, the surgeon must have performed the synovectomy in both the lateral and the patellofemoral compartments, because those are literally the only two compartments left to make the math work.
Which brings us to a super crucial NCCI mandate regarding Code 29880. Code 29880 covers procedures in 2 out of the 3 knee compartments. Because of that, you can literally never report a major synovectomy with 29880 on the same knee. Why? The math just doesn't allow it. If 29880 eats up 2 compartments, you only have 1 left. But remember, the major synovectomy demands 2 unused compartments. It is a mathematical impossibility under NCCI rules to build those 2 together on the same knee.
And finally, Part 4, cartilage and misalignment fixes.
Let's wrap this up by looking at the coding for fixing patella tightness and frayed cartilage. Code 29873 is your lateral release, treating patella misalignment by cutting that tight connective tissue. The golden rule here is entirely based on your primary code's description. If your main open or arthroscopic repair code explicitly states that it includes lateral release, then 29873 is instantly absorbed. It just vanishes as a separate line item. You absolutely have to read the long-form descriptions of those primary reconstruction codes very carefully.
Then there's code 29877, chondroplasty. That's debriding the frayed edges of articular cartilage. First off, you only report this once per surgical encounter, totally regardless of how many compartments the surgeon works in. But furthermore, if this motorized shaving is done alongside those meniscectomy codes we talked about, 29880 or 29881, only the meniscectomy code survives the billing edit. The chondroplasty gets entirely bundled right in.
So we've taken all these frustrating, highly specific, bureaucratic hierarchies and synthesized them. Notice the overall pattern here? Most of these arthroscopic codes are specifically designed to be bundled, unless you meet very rigorous mathematical criteria, like physically enlarging an incision for a loose body, or having enough untouched compartments left over for a major synovectomy. That mental framework is absolutely your key to navigating these NCCI edits.
By adopting this analytical mindset for the CPT manual's strictest rules, you can completely stop leaving your rightful reimbursement on the table. And just as importantly, you'll dodge those exhausting audits and denials. It really just comes down to knowing which code swallows which and exactly what documentation proves a code deserves to stand on its own. So I'll leave you with this to think about. If you look at your own practice's billing history today, how much hidden revenue is currently trapped inside a bundled code? Thanks so much for joining us on this explainer, and we'll catch you next time.